So this presentation is on hematology and neoplasms in children. It's a little lengthy, so you might want to do half one day and half the other day. I would have normally done this on 2 separate days, but this is kind of cool information, at least I think so. And our student outcomes, you need to be able to identify the manifestations of each one of these disorders and what is the nursing care and treatment for the disorders. Epistaxis is a bloody nose. It's common in children. It can be from trauma, from the child causing the trauma by picking his nose. It can be they pick their nose because it bothers them because it's not very humid in their home. They have a dry home. We see it in kids with allergies and kids that have blunt trauma to the nose where they, do bleed, and then it dries up and causes a scab, and then the scab irritates them, or when they go to touch it, it just starts bleeding again. Kids that put foreign bodies up their nose many times will have bloody noses. Some medications that are over drying can cause it, and some medications, that have aspirin can cause it. And we always need to think about the child might have an underlying disease, such as von Willebrand's, which is excessive bleeding. That's all von Willebrand's is, excessive bleeding, but it's excessive. A child with a normal epistaxis should stop bleeding within 10 minutes. So the nursing care when they come to the ER, because the parents think they're, having too many bloody noses, number one is to sit the child up, have them lean forward, pinch the bottom part of their nose by telling them to breathe through their mouth, pinch the nose, and put a cold pack on the bridge of their nose and hold everything for 10 minutes. Generally, that'll do the job. If you have a kid that's kicking and screaming that you just can't hold it for 10 minutes, they won't allow you to. You can put some water-soluble gel or something like something similar to a Vaseline, but only water-soluble, on a cotton ball or a gauze and pack the nose for a little while. And then after, 10 minutes, you can take it out. If it keeps bleeding, they may need to be cauterized. Discharge teaching will be number one to tell the parents all of the risk factors of having, epistaxis and what to do, and remind them holding the nose for 10 minutes is not too long. So iron deficiency anemia is a pretty common disorder in children, and it's one of the most preventable disorders, unfortunately. When a baby's born, they're usually born with enough iron stores to last them 4 to 6 months. The iron stores themselves are built up in the last 3 months of utero. So the baby that's born prematurely are not able to get that iron. So in general, premature babies have iron deficiency anemia just because of when they're born. And they require supplements, and by 2 months they should have started iron supplements. The low birth weight babies also are given iron supplements. Iron supplements to any full-term infant is usually not even considered until they're between 4 and 6 months, when the iron stores should be gone. And not all babies will need supplements. The babies are actually put on formula with iron so that they don't have to have supplements. It would be the 1 or 2 babies that are showing symptoms of iron deficiency and tested and have a low hemoglobin that would need a supplement. Our toddlers sometimes become iron deficient, and one of the biggest reasons is after 1 year old, the baby should be off the bottle. But some babies drink a lot of milk, and especially if they're still in the bottle, they'll drink 8 ounces of milk frequently. So this excessive intake of cow's milk is not a good source of iron, and it may take the place of iron-rich solid foods. And it also, milk does not allow the body to absorb iron from other sources. So what's pretty important is that the child is weaned from formula or breast milk onto whole milk in a cup with small normal amounts with their meals. And then our adolescents are so busy, and they are growing fast, which increases their iron needs. They do strenuous activities. They usually have a poor diet. And the female adolescent begins her menses and loses iron in that way. So here are the symptoms of iron deficiency anemia. And the ones underlined are the ones we see most often, and they're probably the more serious symptoms. You know, the tachycardic, they're pale. And you guys probably realize being pale can be a sign of some type of anemia. Their fingernails become brittle and spoon-shaped. They can develop a systolic heart murmur or heart failure because they don't have the higher hemoglobin. They have a low hemoglobin, therefore decreased blood pressure. So let's talk about the blood tests that will be done. Of course, the CBC, and we know we'll see a decreased red blood count. We know we'll see a decreased hemoglobin because we have a decreased red blood count. And then the hematocrit, because that actually, the hematocrit measures how much red blood cells are circulating in the blood. When we look at the RBCs under a microscope, we'll see that they're microcytic and hypochromic. And I would know those terms. Microcytic means small and immature, and hypochromic means pale. The retic count will be low. The reticulocytes are immature red blood cells. They're made in the bone marrow, and then they're released to circulate for 1 to 2 days before they develop into mature red blood cells. So the retic count measures how many of the immature red blood cells are in the bloodstream, and it gives an idea of the rate at which these cells are made in the bone marrow. And it will be low because usually the reticulocytes are just being produced to replace RBCs and mature RBCs. And if there's not mature RBCs, we'll see a lower amount of reticulocytes being produced. And last but not least is the total iron binding capacity. So one thing to keep in mind if you have iron deficiency, the iron level will be low, but the total iron binding capacity will be high. It's probably the opposite of what you think. Transferrin is a protein that's produced by the liver, and it regulates the absorption of iron into the blood. So the total iron binding capacity relates to how much transferrin in the blood is available for iron to attach. Well, if iron's not attaching to it, there's going to be more and more transferrin available, so that level will be high. So nursing care for children, if the child's breastfed and he's at 6 months or older, he can begin eating solid foods, of course, between 4 and 6 months. And we need to encourage people to give iron-fortified food and include vitamin C, which helps iron be absorbed. The non-breastfed infants need to start off right from the beginning with iron fortified formula until they're 1 year old. The premature infants need to start iron supplements between 4 and 8 weeks of age, and they need to continue it until they're 1 year old. The toddlers, we need to restrict their milk intake for, this says 32 ounces. We don't want them to have more than that or it'll be excessive, and they can become iron deficient once again. We want them to have their milk after a meal, and they are not allowed bottles or cups of milk to be carried around. These children are fatigued, so they'll need frequent rest periods, and many of them will need packed RBCs. Okay, so let's first talk about the iron deficiency anemia iron supplements and how to do it. We need to administer the supplements on an empty stomach. So generally we try to give it an hour before or 2 hours after a meal or formula or breastfeeding. It increases the absorption if the stomach is empty. It can be given with vitamin C, which also enhances absorption. The liquid supplement is very toxic if it's overdosed. So it needs to be kept in a childproof container high up away from the child, and it's suggested that only 1 month of supplement is available in the home so that the child can't get more than he needs. And if the child's MPO, they can have a supplement Z-Track deep into the muscle, and remember, don't massage that afterwards. At first, the child might have some GI problems such as diarrhea, constipation, nausea, but it will actually go away with some time, and the child's body will adjust to it. But we need to warn the parents that the stools will be black. That's kind of freaky for them. We need to teach the parents how to give the supplement. So if it's a baby, we will use a eyedropper or a syringe, and we'll push it a little bit to the side and back of the mouth. But once the children have teeth, we have to be careful because it definitely will stain the teeth. So as they age, they can take this supplement by using a straw. We want to keep it away from the teeth. And remember the clothes as well. It'll ruin their clothes. Because, people complain about, diarrhea or constipation with this. We need to encourage the families to increase the fiber and the fluids in the child's diet. We want to make sure that when they're infants and they begin eating, that they have iron-fortified cereals, and that's one source of iron that we want to give them before we discontinue the supplement, so that we can see how they're going to do on the cereal alone. With children, we want to give them foods that are full of iron. So here's a list here, and we want to make it part of their normal dietary allowance. The parents need to be encouraged that to do follow-up laboratory tests to determine the effectiveness of the treatment. And the parents also need to be aware that the child's treatment will be, noted through the hemoglobin levels. But we kind of watch for them to increase, but we wait till at least 1 month. And if they're not increased in 1 month, the child needs to be reevaluated. The dose needs to be reevaluated, how they're giving it to make sure it's absorbed. And if all that seems to be within normal range, the hematologist needs to do other tests to see why this treatment is not working. Complications of iron deficiency anemia is, unfortunately, it's very frightening, but it's delayed development. Remember, the hemoglobin carries the oxygen to the brain. And if that's not happening, the child could begin having cognitive issues. So we assess, as clinicians, their level of functioning. We try to encourage improved nutritional intake. And we refer to developmental services to monitor this child carefully for a developmental delay. So sickle cell anemia, it's a group of disorders that is inherited from one's parents. It's autosomal recessive. So what we do know is one parent can have a trait and one can have the disease, and the child will have the disease. Both parents can have the trait and the child will have the disease or a trait. One parent with the disease and the other parent normal will not cause a child to have the disease or trait. And one parent with the trait and another parent normal will also not cause the child to have sickle cell. The only way the child will have sickle cell anemia is if both parents have the trait, or one parent has the disease and the other person has the trait. Sickle cell anemia is the most common type of sickle cell. There are others, and we see it in African Americans, Mediterranean, Indian, and Middle Eastern descent. This is where the red blood cells become real sticky and kind of rigid, and they're shaped like a sickle, hence the name sickle cell. They're irregular red blood cells that don't mature, and they get stuck in the blood vessels, blocking the flow of the oxygen to the other body parts, which causes severe pain. So we have people that have the disease, which will have the pain and all the symptoms. And then we have people who have the trait, which has no symptoms and no pain. Sickle cell anemia, symptoms can be, they have the abnormal shaped RBCs. And the RBC lifespan is very short. We know that our RBC lifespan is usually 120 days on a normal person. But on these kids with sickle cell anemia, it can be like 4 to 6 days or so. They are immature and they die out quickly. And they're, I can't remember the word they used, like distorted looking. The child's family has to have a history. And these poor kids go through a lot of pain. And the pain are episodic, and they're called crises. I want to see if I have it here anywhere else. No. If they're an adolescent, however, they could have chronic pain as they grow. These children in general have delayed growth because red blood cells carry the nutrient and oxygen, that helps us to grow. They tend to have frequent infections, and sometimes some of the children could be jaundice if it's sickling is affecting the liver. Definitely will have swollen joints, and the name for swollen joints in this situation, because the blood will pool in the joint area, is called hemarthrosis. They can have swollen hands and feet, called dactylitis. They can have headaches. Headaches are dangerous because we think the central nervous system is involved and they might have a stroke, which is something that can happen with sickle cell anemia. They can have shortness of breath, fatigue, and tachycardia, which is another warning sign that they can have chest crisis, which is a pneumonia that comes out of nowhere, and if not treated immediately, could actually be fatal to the child. We see them with infections, and unfortunately, the sickle cells can block the blood vessels to the eyes, causing retinal damage. Lab tests that are done. Definitely a CBC will be done. The sickle turbidity test is done, and it's actually done in the newborn stage, which will tell us if the child may have a trait or the disease. It won't be definite, but it's something that needs further evaluation. If someone doesn't have this sickle cell turbidity test done as a newborn, it can be done any time in life, anytime sickle cell is suspected, but it won't tell us if they have the disease or not. So to go one step farther, if the sickle cell turbidity is positive, the child needs a hemoglobin electrophoresis, which will define whether it is a trait or a disease. The transcranial Doppler test is done to make sure that the child doesn't have any clogged vessels going up to the head or the cranium, and possibly on the verge of a stroke. Therapeutic measures is the hydroxyurea, the penicillin for prophylaxis. They'll do exchange transfusions, and because of the exchange transfusions, which are actually done frequently, they'll need chelation. I've said this a million times. Chelation treatments with deferoxamine, and what that does is it'll take the extra iron out of the blood that all the transfusions have put in. Extra iron can be toxic. The children usually will need oxygen. They'll be on complete bed rest. They'll need analgesics and they'll need fluids. So if you asked me, when a child comes in, in crisis, in pain, what's the first thing we do? The first thing we actually do is the very last one on this list, fluids. We start an IV and get them hydrated right away. Because if we can get that blood thinned out, then the blood will carry the sticky crescent shape RBCs through the body. But what happens is the blood gets more and more sticky and thicker, and these crescent shaped RBCs get stuck at the joints, causing all the pain, and then the crisis evolves. So fluids is number one, along with pain. But get that IV going and then give them something for pain. Fluids, analgesia, and then last but not least, oxygen will just make them more comfortable. It's not going to fix the situation until we get that blood flow moving. Vaso-occlusive crisis is when the child's blood gets thicker and the sickling becomes pretty bad, where it's clogging up the blood vessels. So this is a concept map showing you the effects of a vaso-occlusive crisis. So there's several different types of vaso-occlusive crisis. The most one we see most often is the one related just to pain and swelling. However, the acute chest syndrome one is very dangerous. The child will present with chest pain and coughing and shortness of breath and fever, and x-rays will be done, and they'll see that the kid usually has a bad pneumonia. But what we worry about is sometimes they could have a fat embolism or a pulmonary thrombosis, and that they need to be treated immediately. The splenetic sequestron crisis, unfortunately, the sicklers attack the spleen and cause it to enlarge. Because the red blood cells can't get through, they'll sit there and the spleen will become enlarged. It's associated with the RBCs and the platelet counts. It's due to a sudden pooling of a large amount of blood in the spleen. So there are certain triggers for crisis. The children aren't always in pain and always being admitted. One of the most common one that we have no control over is the sudden change in temperature. Where up north, when the weather changes quickly, the children tend to be admitted with the pain and the swelling joints. Out in the cold can do it. So if the child goes skiing, which is not a good idea for these children, it will trigger the crisis. Strenuous exercise, although exercise is important, and we do encourage these children to try to do similar things to their peers, Strenuous exercise puts stress on the body. Dehydration, definitely, because one of the first signs of the crisis is dehydration. So if the child has the flu, the family needs to know to notify the physician, because dehydration can be very serious, and it's better to have them be hydrated maybe for a couple hours in the ER than to go into crisis. Infections definitely will set off a crisis. Stress in high altitudes, going to Colorado on a vacation can cause an issue. And as the child gets older, hopefully we're talking older, alcohol is a definite trigger for these. So their nursing care. The little pneumatic HOP, hydration, oxygen, and pain management is the most important. And hydration is number one. When they come in and they're admitted, monitor for an enlarged spleen. These children need to rest, and if they're hypoxic, they can have oxygen. Their fluids and electrolytes should be monitored. INO, daily weights, oral fluids also need to be monitored. Pain control is generally at first done by a PCA if the child's old enough, morphine IV, and later on they can go down to acetaminophen or whatever is ordered for them. These children will come in with swollen, painful joints, so they cannot have ice to their joints. So warm packs to the painful joints and elevating their joints also helps. Many times they need blood products. We look for infection and we try to prevent it. Immunizations are important for these children. Getting chickenpox could actually kill them. We monitor their CBC and their liver functions. Unfortunately, there are some complications, and an acute chest syndrome is definitely one of them. That's a serious vaso-occlusive crisis. And the second one, of course, could be the CVA. So we monitor for severe thoracic pain, cough, dyspnea, and tachycardia and hypoxia. Discharge instructions, and this is, considering this is probably a newly, a child in for maybe their first crisis, or parents maybe that are non-compliant that you have to remind it over and over again. So social services should be involved to help these people. And the parents need to know the symptoms of a crisis and possible triggers so they can avoid the triggers. Rest and good nutrition is important, as well as good hand washing and the need to avoid infections and infectious people. So restrict association with ill children and friends. Although we promote, visitors, they have to be healthy. When they're in the hospital, the specific instructions on fluid intake can begin. So you could, put 4 ounces of fluids on the bedside table and say to the parents or child, you really need to have this in by noon, and then I'm going to bring more. And then you can show the parents how much fluids these children need on a daily basis. The problem sometimes is they don't know, and the child's really not drinking enough, and he's slowly dehydrating himself. Once the child is diagnosed, they need genetic counseling to see what the risks are of other children having sickle cell anemia. And these children definitely need immunizations, and the parents need to be encouraged to do immunizations. And they should have some kind of an ID bracelet that tells us that he has sickle cell. So hemophilia is actually a group of bleeding disorders, and it's characterized by the impaired ability to control that bleeding. It's due to a lack of a factor that's required for the blood to clot. Many times we don't know a baby has hemophilia. That's not something that's tested for regularly until, there's some symptoms. They start teething and they're bleeding, or they're learning to pull up and they fall, and, they have excessive bruising. There are actually three, but the third one's very rare. So generally textbooks only talk about A and B. And this is a genetic disorder. It's an X-linked recessive disorder. An X-linked recessive disorder. So in hemophilia, A is the most common. It's what we see most often. And it is a deficiency of factor VIII. Hemophilia B is seen occasionally, and it's known as the Christmas disease because the person that founded it, his last name is Christmas, and it's a deficiency of factor IX. The symptoms is active bleeding. It can be, once again, gums, epistasis, hematuria, tarry stools. One of the things that we see, and we also see this in the child with sickle cell, is the term hemarthrosis. I always want to put an extra syllable in that. And what that is it's, oh my goodness, it's joint pain, stiffness, redness, swelling, loss of range of motion, and deformities. And what it is the blood pooling in between the joints of whatever, the knees, the elbows, the wrists, the feet. And once it pulls in there, you can't bend that joint. And every time the child goes to bend it, it's so painful. Unfortunately, it can be very serious, and it can affect the neural system. Once again, they could have a, cranial bleed. So we'll see headaches, slurred speech, and decreased consciousness. Kids that have prolonged nosebleeds is sometimes a really good sign. And so, when we talked about epistasis, and I laughed, I said people come in, they just don't put pressure on long enough. Well, to some people, 10 minutes is a long time. But actually, that's a normal range of time for a nosebleed. Prolonged would be much longer than that. They'll have excessive bruising, and they have activity intolerance. Okay, so when we look at the CBC, this is really important to know. The platelet count probably will be normal. It almost always is normal. But the clotting factors will be abnormal. So if we have a kid coming in with frequent bleeding and we do a CBC and we see that their platelets is okay, the next thing we'll do is, of course, the clotting factors. The prothrombin time and the whole blood clotting time is normal, but normal. I want you to remember that. The partial prothrombin time, the PTT, is prolonged. And then the factors. A is for factor VIII, and B is for factor IX. DNA testing or genetic testing needs to be done at this point. So this slide's about the medications you need to know that we give to kids with hemophilia. From a child that's mild to moderate, he can have the DDAVP, and it is a synthetic form of a vasopressin that increases plasma factor VIII. Imagine that. And it's actually called, factor VIII is actually called the anti-hemolytic factor. It's not for kids that have severe hemophilia, and it's not for those that have hemophilia B. It's only for A. The child can have it before dental procedures or any surgical procedures, anything invasive. And sometimes it's given just routinely to children who have had frequent crisis. Can't get the words out. The second one is a little newer, and it's not the recombinant factor that we talked about, but it's factor A concentrate. And they now consider it to be a medication, and the recombinant factor comes from blood plasma, where this does not. So it does not carry the risks of blood products. This should be administered immediately if any injury occurs. So if the child is away from home, he'll have to go to the ER. Otherwise, the parents or the caregivers should have a prescription of this kept in the refrigerator, and they're going to be taught how to administer it to the child. And as the child gets older, he'll administer it himself. The children generally will need frequent blood transfusions to make up for the, loss of bleeding. They will also be given corticosteroids to treat things like hematuria or hemarthrosis or chronic pain. Last but not least, another newer drug is EACA, or aminocaprosidic acid, and it prevents clot destructions in the mouth. So it's used for mouth trauma. So this is really a good prescription to have on hand, especially for those younger children that are just learning to walk and ride their bike. It has to be swished and swallowed. So nursing care is no NSAIDs are to be given. They have a aspirin-like effect and can enhance bleeding. So they can have acetaminophen, but no NSAIDs. No rectal temperatures or any unnecessary skin punctures. So no pierced ears, no belly button ring or whatever. When the child does have needle sticks, pressure needs to be applied for about 5 to 10 minutes. At home, in the hospital, monitor urine, stool, and NG fluids or any body fluids for blood. If they're bleeding, control localized bleeding. And if it's in a joint, mobilize, elevate, and ice the joint. The child needs frequent rest periods, and monitor for infections, and teach good hand washing. Also, visitors that may be ill should not be around this child. They're at high risk for infections. A soft toothbrush is important. And one other thing I don't have on here, if they're adolescent girls, this is more a boy-dominated thing. In fact, I think it's very rare that it's a girl. But if there is, they cannot use tampons. And the most important thing is the nurse should observe for a neurological impairment. We're looking for an intracranial bleed. So they need to look for headaches, loss of consciousness, tachycardia. So when the child's ready to be discharged, the family needs to be taught rest, immobilize, elevate, and apply ice. The infants will need a padded crib at home and additional padding to their clothing so if they fall, they don't get hurt. People use knee pads and helmets and these children all the time. Once the bleeding has stopped, the child needs regular exercise and physical therapy to prevent the joints from getting distorted. The family needs to be taught how to administer factor VIII. It is IV, and the family could be taught while the child is 2 years old or above. And then the child is to be taught how to administer his own factor VIII, 8 to 12 years. Immunizations must be kept up to date, and the environment needs to be free of clutter to prevent the child from falling. The family needs to know the signs of bleeding and hemarthrosis. If the child has a head trauma, they need to be taken immediately to the ER to be treated and see if there's intracranial bleed. Support groups are very helpful, and numbers and names are given to the family, and many do use support groups in this situation. And last but not least, if bleeding does occur as the adolescent boy becomes, whether he shaves or whatever, we need to teach them to apply pressure for 10 to 15 minutes. Some complications in general. For uncontrolled bleeding, administer the appropriate factor, administer a blood transfusion, check neurals, and they'll be put on prophylaxis antibiotics. To prevent joint deformities, rest, immobilize, elevate, and apply ice to affected joints, range of motion and physical exercise, and encourage the proper weight. So the following slides, we're going to talk about the neoplasms or the cancers that are most prevalent in children. We'll first discuss the actual disease, and at the end, there'll be more detailed information on tests and procedures and nursing care. So neoplastic disorders in children, risk factors can be a family history. It can be exposure to secondhand smoke or excessive sun exposure. Some children are put on some immunosuppressive drugs, such as those kids that have juvenile idiopathic arthritis and some endocrine issues. And the side effects for a lot of those drugs is like a lymphoma or a cancer-producing cell. Children that have excessive radiation exposure, which would mean, living next to a toxic plant or warehouse. Children that have had Epstein-Barr infection are actually put at risk for cancer. Male children, white children, and children with Down syndrome. And then the little diagram shows you the most common pediatric cancers. So bone cancers, and the first one we're going to talk about is osteosarcoma, which is the most common bone cancer in children and occurs most frequently after age 10, after a growth spurt. Most of the time, it occurs in the femur, but it can occur any other places as well. So the osteomatrix of the bones, the blood vessels, or the cartilage. We see it mostly right around the knee, and that's why I put that diagram of the knee with the cancer on it. The area will usually swell up, and so that the child who's 10 or thereabout can tell you that I have this like swollen bump on my knee. It can cause a limp, and the pain is only directly where the cancer is. And what's interesting, because it is pretty much they feel it in the joint, it can be relieved when they flex their joint. Generally, there'll be palpable lymph nodes near the tumor, so if it's in the femur, it'll be in the groin. The children usually suffer from anemia, infections, and weight loss. The second one, which is not as common as osteo, however, is a little bit more life-threatening, is Ewing sarcoma. And we see Ewing sarcoma generally under the age of 30. So once again, we're probably talking about an adolescent. And with this, it's not in the joints, but it's in the shafts of the long bone and trunk bones. And it can be deadly. So prognosis depends on how quickly the child is diagnosed. Once again, it'll be painful. There'll be swelling and tenderness near the affected area. However, sometimes parents pass that off as growing pains. Bone pain is usually worse at night or when they're physically active. They frequently complain of fatigueness, and they'll develop a fever with no known cause that won't go away. They'll have weight loss, and many times they'll x-ray that area if they keep complaining about the pain, and that child will have some broken bones with no known cause. We see it mostly in Caucasians. And I found this little statement in one of my NCLEX notes. It said, Ewing sarcoma is a difficult and life-threatening type of bone cancer. It can appear anywhere that a bone is located. Surgery is an attempt to stop the spread of the disease to the rest of the bones in the body. So many times with Ewing sarcoma, amputation is the only answer, although there's other treatments. So they usually do a surgical biopsy, and then they know the child needs some kind of surgery. So they'll institute chemotherapy right away and try to shrink that tissue as much as possible. For osteosarcoma, methotrexate is like the drug of choice in high doses. And then in Ewing sarcoma, vincristine is usually the drug of choice. These are old drugs that have been given for years, and these are the best drugs in these situations. The surgery can be one of two things. They can do a limb salvage procedure, or they can do an amputation. And generally speaking, their goal is to do the limb salvaging. They start off trying to do the limb salvaging procedure. Before and after surgery, the child will go through chemotherapy. And generally speaking, before surgery, they'll do some localized radiation to try to shrink that tumor as small as possible. This is kind of wordy, and it's for you to read, but it talks about the limb sparing surgery and how it's done and what is used for it and why they do it. So please read this over. Nursing care, the first thing is to assess for phantom pain. Researchers don't really know why children, have pain where the extremity was once it's gone. But they think the spinal cord takes a while to adjust to something being different in the system, and therefore it keeps sending out messages that there's pain where the extremity had been. Studies show that it's generally children that had a lot of pain prior to the operation. They have found that some of the drugs used for seizures have been very helpful. The most common one is atriptyline. It actually tells the brain not to send those painful signals to the area or the body, and that's why it's successful. It's not successful with everyone, and there's some trials right now using Neurontin or gabapentin and a few other similar drugs that work on nerve endings. One thing to be sure is to assess the stump and make sure there isn't actual pain there. However, phantom pain, they usually complain about pain and spasms and tingling, like pins and needles, and generally speaking, they'll point lower than the stump. But make sure it's not a pain in the actual surgical site. You'll do routine post-op care, check the IVs, any dressing changes that need to be done, NPO to they have bowel sounds, etc. Generally, there will be a temporary prosthesis given to the child with occupational and physical therapy, and they'll learn how to walk on it, while a nicer looking one will be developed for that particular child. The temporary prosthesis sometimes doesn't fit very well, so you need to check to make sure it's not rubbing that stump raw. They'll go to OT and PT, and there'll also be some support groups and some mental health counseling that'll be done. Complications is skin desquamation, and that usually will be around the stump area. It'll start peeling, or unfortunately myelosuppression. A rhabdosarcoma is under the bone cancers because it begins a malignant tumor of the striated muscle cells that begin in the skeletal muscles. I actually wrote a couple more things down about it. There's actually two types of rhabdosarcoma, and the one we see most often in children is called embryonal, EMBRYONAL, rhabdosarcoma, and it's actually usually formed while the child's in embryo, and it's seen in children under 5. And this particular one affects the head, neck, bladder, vagina, prostate, and testicles. And then the other one is the alveolar rhabdosarcoma, and it affects all age groups, and it affects the large muscles of the arms, legs, and trunks. Most of the time, we see the soft tissue sarcoma, and it accounts for 7 to 8% of all childhood cancers, and it is the most common type of soft tissue cancer. 2/3 of them are diagnosed younger than age 10, and more males than females are diagnosed, and more Caucasians and African Americans are diagnosed. So it usually, let's see where we're at here. It's a hard, non-tender mass, but it's an obvious mass. Like, look at the little child to the right, his eye. It occurs in muscles mainly around the eyes, head, and neck, and extremities. It can be GI and GU system as well. We see it most often before age 5 again, and the child will first have a surgical biopsy, and then they'll do treatment, which is a local surgery. They'll do radiation and chemotherapy. Now, rhabdomyosarcoma in adults is benign, most of the time benign, but in children, unfortunately, they do not have the same prognosis as adults. Now we'll talk about blood neoplasms. And the first one is leukemia. Now remember, leukemia in general is a group of malignancies that affect the bone marrow and lymphatic system. It is caused by bone marrow dysfunction that leads the child to anemia and neutropenia. It causes an increase in the productions of immature WBCs, which leads to infiltration of organs and tissues and a deficiency of platelets and RBCs. So these kids sometimes, the first symptoms is some type of bleeding, bruising. There's more than one type of leukemia, and I'm listing 2 here, but there's even a third one that's not very common. And the third one is, I think the third one they call ANLL, and it has the Phoenix genetic factor. And unfortunately with that particular one, the children do not respond to treatment. But ALL is, as before, lymphocytic leukemia, and it's the most common type in children. In fact, 80% of them of all leukemias are ALL. We see it primarily in Caucasian children. They're young, 2 to 5. They're usually males, and we also see it in children with Down syndrome. And I have it kind of written out here for you. The malignant cell involved is the lymphoblast, which is the other name for the immature lymphocyte from our stem cells. Interesting enough, relapse most commonly occurs in the testicles. AML, which is myelocytic usually, but I have, I think maybe how your book has it, myelogenous or non-lymphoid leukemia, unfortunately is not as nice. It's the overproliferation of myeloblasts, and they're immature, once again, cells. It limits the production of red blood cells and platelets. We see this mostly in a little bit older children, adolescents, and of course adults. The prognosis for AML is not very good. But symptoms of leukemia in general, early symptoms that sometimes are overlooked: low-grade fevers, bruising and petechiae. The child will become pallor and listless. They'll complain about abdominal, joint, and leg pain. They'll slowly have an enlarged liver, lymph nodes, and joints. When those symptoms, or if those symptoms are ignored, the pain becomes the #1 issue with the children. It's very painful. Rib pain is one of the symptoms. Swelling of the wrists and ankles and the pain associated is the other. They'll soon, because their platelets are so low, we'll see hematuria. I don't know what I said. Mouth lesions. The kidneys and the testicles become enlarged. And unfortunately, with a low platelet count, they can have a cranial bleed, so intracranial pressure. This was a great chart I got a long time ago, and I've saved it. And it really shows, using a concept map approach, the way leukemia progresses. Specific tests done just for leukemia is, of course, a platelet count, hemoglobin, and hematocrit, which will all be low. When they do the CBC, blast cells will be there where we really shouldn't see any. So anytime you see a blast cell in a CBC result, you know that this is not a good sign. A bone marrow aspiration will be done, and it's used to identify the type of white blood cell involvement, therefore the type of leukemia. X-rays of the long bones are done. It will show lesions caused by invasions of abnormal cells. And lumbar punctures are done. They want to see if there's any blast cells in the CSF. This is one of the last tests that are done, usually after the diagnosis has been made and the type of protocol has been decided upon. They'll do it to make sure there's no blast in the central nervous system. But at the same time that they do the LP, they will extract the fluid, but they'll also inject the very first dose of chemotherapy drug. It's called giving it intrathecally, and it starts the whole chemotherapy process. Generally, it's only done in the beginning of the regime. I liked this picture of a bone marrow aspirations, and it shows the different sites that can be used. Of course, the most common site is the hip. The child for this will have to be sedated heavily, and then they also apply local anesthesia to the site. The child will be held very similar as they are to an LP. Sometimes they'll do this under general anesthesia in the OR, but in the past it hadn't been. And it'll be a nurse to help the physician and a nurse to hold the child. Now we're going to talk about tumors and malignancy of the lymph system. We'll talk about organ tumors, brain tumors, and then the malignancy of the lymphatic system. So organ neoplasm, the first one is a neuroblastoma. And this is the most common cancer of infancy, with the median age being 22 months, not quite 2 years old. Unfortunately, 70% of the children diagnosed has already metastasized before they're diagnosed. This type of a tumor is solid, and it's considered an extracranial tumor that arises from fetal cells that form the adrenal medulla and the sympathetic nervous system. So in utero, this tumor was created. Another way of saying it is a malignancy arising from the adrenal glands, the sympathetic nervous system ganglion cells outside of the cranium, and they can arise anywhere along the sympathetic nervous chain. It can also be retroperitoneal. It can be pelvis, neck, chest, and head. The primary site for a neuroblastoma is the abdomen, and secondary would be the brain. Once again, it's not usually diagnosed until it's advanced, and diagnosis is made with the CT, MRI, and PET scan. chest x-ray, skeletal survey, bone marrow aspiration, and this metadobenzene guidine scan and biopsy. So neuroblastoma, when it's seen in the abdomen, it generally presents as an asymmetrical, firm, non-tender mass in the abdomen that crosses midline. So it's not on one side or the other, it's usually in the middle, and it's asymmetrical. It can cause urinary symptoms. In fact, it's known to when it's in the abdomen because of the compression on the renal structures. Signs of metastasis can be periorbital edema, supraorbital ecchymosis, and exothymos. More signs of metastasis is lymphatic apathy, weight loss, anemia, and fatigue, hepatomegaly and splenomegaly, bone pain, respiratory symptoms, and occasionally paralysis. Unfortunately, neuroblastoma tumors spread rapidly and metastasize rapidly, and the prognosis is not good. The treatment is usually, they start off with radiating the area where the tumor is, and then surgery follows. Chemotherapy is afterwards, and occasionally the tumor will regress, but most of the time it doesn't touch it. Diagnosis is the best if it's made prior to 18 months old. Those children tend to do a little bit better. Another organ, neoplasm, that we don't want to get confused with neuroblastoma, is called a Wilms tumor. And this is the most common childhood cancer of the kidney. It sits in our kidney. Metastasis is rare with Wilms tumor because it's encased in a protective little sac in the belly. Generally, surgery to remove the tumor, and sometimes they need to take, if it's only one tumor, the kidney and all the structures with it. Sometimes they can just get the tumor. It'll be followed with chemotherapy. When you see a mass on the abdomen, never palpate it. We never palpate a Wilms tumor because it'll cause the casing or the sac around the tumor to break. It's very, very delicate, and then the tumor will spread and metastasis will occur. This particular tumor is unilateral. Very rarely is it seen on both kidneys. It is unilateral. It'll be on one side of the kidney. This child will also have urinary symptoms. So once again, it's the most common childhood tumor on the kidney. It's a solid tumor, and it presents as an abdominal mass that is firm, non-tender, and unilateral. We see it mostly in children before age 5, and 5% of the children have it. Someone else in their family has it. Metastasis is very uncommon with this. This is usually a happy ever-ending story. However, we do see weight loss, enlarged liver, spleen, and anemia. Brain tumors. Brain tumors in general, there's several names of them, but 25% of all cancers the children suffer from. And the most common solid tumor is seen as a brain tumor in children. It mostly occurs in the brainstem or the cerebellum. It can originate from any cranial cell. The most common one is a glia tumor, and the second is an astrocytoma. Neither one of those are good to have. Pain Depends on the location of the tumor and the size of the tumor. So children will complain upon getting out of bed of a headache. So, kids get headaches, and especially stressful kids. Sometimes as they grow, they get muscle pain like in their neck causing headaches. But headaches upon awakening is something that needs to be addressed. Vomiting unrelated to eating, ataxia, dysmetria, dysarthria, nystagmus, behavior changes are all independent symptoms, but when together, we really start looking for a brain tumor. Prior to trying to remove the tumor, radiation is done. And the newer radiation now is the proton radiation, where they can direct it right at the tumor. And then the child also will receive chemotherapy. Last but not least is the malignancy of the lymph system, primarily the lymph nodes. And Hodgkin's is the most common, and we see it in adolescents. We don't see this younger. It's a painless and large subclavicular or cervical node. And the child presents with a chronic non-productive cough, abdominal pain, low-grade fever, and anorexia. They'll complain of itchiness, pruritus. They'll have night sweats, weight loss. So Hodgkin's disease is treated with chemotherapy and radiation, usually radiation towards the lymph nodes that are present. And it has a great prognosis. Approximately 90 to 95 of children can be cured. So I put here that the following slides are important. We're going to talk about stem cell transplant because it's kind of overtaking the bone marrow transplant. It's a little safer and it's more available. And we're also going to talk about a generalized list of symptoms and tests and nursing care for any child with neoplastic disorders. So the stem cell transplant is indicated for children who have AML during their first remission. They need to get into remission in order to do this. It's really hard to get kids with AML into remission. So if it happens, they really need to be ready for a stem cell transplant. For children who have ALL, generally speaking, they wait till after the second remission. These children aren't as hard to get into remission. They have a better prognosis. So they generally wait for the second remission to see if they actually need it. What's usually done is the children receive their own stem cells if possible. So usually what they'll do when the child goes into remission is they'll put them in protective isolation and they'll destroy the tumor cells with high doses of chemotherapy and radiation. So they'll usually get rid of all cells practically. After the tumor cells are destroyed, the child will receive either a bone marrow or a stem transplant. They're both given through IVs, and it may take 2 to 6 weeks to be totally implanted. Here is a great diagram, that you could probably find on the internet. I had this one for a while, but I'm sure it's still there, that shows the process. And then this is a pretty cool thing. And guess what? It's given to us by the MS people, because now they're trying to do some stem cell therapy with the MS children, young adults. So it explains that the stem cells are removed from the body after chemotherapy. And it's put into a machine that separates the cells, and they'll freeze the stem cells until the child is ready for the administration of it. They'll continue to do more chemotherapy to wipe out the bone marrow and the immune system, and then they'll give them the stem cells, and it takes the body 3 to 6 months or longer to recover from this procedure. So pre and post stem cell transplant, the nursing care. So before the stem cell transplant, coordination of high doses of chemotherapy and radiation is done by the primary nurse. Once the bone marrow is clean of cells, oh, thank you, Rudy. The child will have IV infusion of stem cells, and the nurse does that. The child will, from the very beginning, be in protective isolation, and everyone will be required to wear masks, gloves, and gowns. Because of the risk of infection, no flowers, plants, fresh fruit, or vegetables. And really, I should have put on here, only the immediate family can visit if they're healthy, and no one else. The child's at risk for bleeding and infection until the transfused stem cells grow and are absorbed by the child. Hydration is very important, and consistency with the same nurses caring for the child, so that there's not a lot of different types of risks of infection. Gastric and or hepatic diseases are frequent complications. So conditioning regimes that usually consist of high doses of chemotherapy, radiation, or both are done, but they can cause mucositis. This is like those sores in the mouth that kind of are yeasty looking, and it's not only in the mouth, but it goes through the esophagus and down to the GI tract. So the children will complain about the soreness in their mouth, soreness when they swallow. They'll have stomach ulcers, and we'll see diarrhea or stomach cramping. Many times these kids will need IV narcotics, and they cannot eat because it's so painful, so they'll be put on TPN. The nurse's job is to monitor for rejection. So the children will receive anti-rejection medications, and they're started in the hospital, and once the child is stable, we can start teaching the families about how to do it. It's very important that these drugs are given and given on time. We want to prevent infection and teach this with careful hand washing, and once again, consistent nursing care, selective cohorting. And we want to pay a special attention to any wounds or IV sites, because that can be a source of infection. We want to look at their skin for rashes and monitor for diarrhea and changes in the vital signs. And these children, once again, will be in protective isolation. So we can see graft versus host, or just graft rejection. They can have bacterial, fungal, or viral infections, which will cause them to reject. They will have problems with their stomach, intestines, and liver and lungs, and it needs to be treated promptly so more infection doesn't set in. Sometimes this can cause complications with their nervous system, and they begin having twitches or seizures. And sometimes it's caused by the late effects of the transplant. The complications of the nervous system are late effects, and the child needs to be watched closely for these symptoms, and it needs to be reported. So in general, the manifestations of the neoplasms that children can get are on the left. The labs and diagnostic tests are on the right. So therapeutic and medications for any of the neoplasms is, of course, chemotherapy, surgery, radiation, bone marrow or stem cell transplant, analgesics, antiemetics, corticosteroids, self-stimulating medication, which is pretty cool. It's the epotin alpha is usually what's given. Topical anesthetics, antihistamines, and antibiotics. I've talked about most of these throughout the slides. Nursing care, once again, monitor for anaphylaxis for at least 20 minutes after the beginning of the chemotherapy infusion. So stay with the patient, take vital signs, and stay and watch for a reaction. The child needs to be medicated with antiemetics before the chemo started, after the chemo has completed, and then for 24 hours to decrease the signs and symptoms of nausea. Also, it's wise to keep the smell of food out of the child's room. Do everything possible to prevent nausea. They'll be in protective isolation again, so strict asepsis, bleeding, and neutropenic precautions. Even though we're going to keep the food out, we want them to have small sips of liquids frequently and monitor their vitals. Visitors need to be healthy to visit, and generally speaking, at first, when the child's very neutropenic, it really should be only the immediate family. Do not force the child to eat, but you can offer favorite foods. Monitor weight, pre-medicate for any painful procedures whatsoever. Prepare the child for hair loss and, provide for their body image by allowing them to manage what's going to be done with their hair. Because of infection, cleanliness and regular hygiene is very important, and because of bleeding, soft toothbrushes should be used. To help their esteem, the child, when they're feeling well, can wear regular clothes. Try to keep them on a routine and be sure they're doing their schoolwork. Encourage talking about their fears. Many times they overhear things and they don't want to talk to their parents about it. And when the family's there, give them uninterrupted family time. Once again, no spicy foods, and monitor their mouth for mucositis. Education, explain all procedures to the caregiver and the child at their level appropriately. Explain what to expect as treatment progresses and side effects. Sometimes physicians forget to do that. And then give them ideas on how to handle the side effects. Distractions, music therapy, pet therapy. Ensure the caregivers understand what's going on and the statistics of their prognosis, that they're not hoping for a miracle. If not, the physician should be notified. And discuss participation in support groups or other support. Sometimes people have their own support through their churches and clubs and friends, but the hospital usually has a support group. So chemotherapy phases, the first is induction. And remember, it's during that time that the LP is done to see if there's any cells in the spinal fluid, but it's also to give prophylactic therapy. They inject chemotherapy intrathecally, and that's probably the only time you'll see that done is during the induction phase. And then they go through their chemotherapy regime, and it may be once, it may be twice, but however long it takes, the child will eventually get into remission. Once they're in remission, they still get maintenance chemotherapy. We look for side effects, which is the mucosal ulcers, the skin breakdown, neuropathy from the medication, anorexia from the chemotherapy, low platelets and bleeding, and hemorrhagic cystitis, which is, the chemotherapy can cause hemorrhagic cystitis and alopecia. And once again, this is kind of saying it again, but remember they need to be in reverse isolation or protective isolation. If nothing else, these children need their temperatures monitored. It can go up and down. They can receive other vaccinations, but not the live vaccinations. And we request that their siblings do not receive the live vaccinations as well during this time. Always apply pressure to their puncture site, secondary to bleeding. Not that they feel up to it when they go home, but we send them back to school, and they do their chemotherapy as an outpatient, so no contact sports. We need to teach the families how to check their urine and stool for blood, and we give stool softeners so that they don't become constipated and have to bear down or strain, which can cause rectal hemorrhaging. And this is the end, and these are my probably my favorite, the kids I remember the most. On your left is Marcel, and Marcel had he started off with sickle cell, and as they were learning how to avoid the triggers and he was doing better, he was diagnosed with leukemia, and he passed away. On the right is Latasha, who had a rare form of cancer called sinus histiocytosis. It was the first time this was reported in a child. It was rare as it was, and then this was the first time it was reported in a child. And when she received her trach, her family didn't want her to come home anymore. They didn't want to take care of it. And actually, there was some other issues in the home. They were actually written up for medical neglect. However, poor little Tasha, nobody wanted her, so she came home with me for a while. And, we had a great time together until she passed away. And I will see you in class. I did put a bunch of links for you. Maybe it would make it more clear, talking about stem cells, and especially those of you that want to go into pediatric hematology. But there's one particular link I put on there, and it's talking about the family having the right to allow the sibling to donate. And it's a real controversial situation. So we're going to kind of talk about it in class a little. And I actually would like a little debate. So think about read that article and think about how you feel about that. There has been movies made where people have had a child so that the child can donate the bone marrow for the sick child and so forth. I even had a patient that did that. But they did it so that they could keep the umbilical stem cells, so no harm done to the other child. But how do you feel about the other child just expected to be a donor and go through what donors go through without them having a say? See you in class.